Hello aspirants, and welcome to this Rungta IAS Academy Explainer. Today, we are dissecting a deeply critical issue that sits right at the intersection of your General Studies Paper 1 Society syllabus and your GS Paper 3 Science and Technology sections. We're talking about decentralizing mental health treatment. Whether you're framing a high-scoring mains answer or prepping for the personality test, the nuances we're going to cover today are absolutely essential.
Thank you, sir. All right, class, here's our roadmap for today. We'll start with the 85% treatment gap, then look at distress versus disorder, the medication bottleneck, the stepped care model, some brilliant community case studies, and finally, an administrative synthesis. Let's get started.
Section 1. The 85% treatment gap. Analyzing the data. I want all of you to grab your notebooks and write down this staggering data point. 85%. That is the current treatment gap in India. Nearly 85% of individuals suffering from common mental disorders receive absolutely no formal care. Why? Well, we simply don't have the specialist workforce concentrated in our rural and semi-urban areas to bridge this massive divide using traditional hospital-based methods. It's a huge structural bottleneck.
Moving to Section 2. Distress versus disorder. Conceptual clarity.
You see, a major systemic flaw exists right now in our busy primary care clinics. The lines between everyday distress, things like work stress, interpersonal conflicts, or grief, and actual clinical disorders get completely blurred. General physicians are incredibly pressed for time, and they usually don't have access to psychosocial services. So what happens? They often resort to symptom suppression through medication, rather than actually taking the time to understand the patient's context.
Which brings us to Section 3, the medication bottleneck, pharmacology versus psychology.
Aspirants, I want you to use this specific terminology in your exams. Let's talk pharmacology. Antidepressants, specifically SSRIs, are essential, literally life-changing medications for severe cases. Now, they are not conventionally addictive, though they do have discontinuation symptoms, something actually highlighted recently in a UK House of Lords debate. But the real danger? That lies in sleeping pills. They are frequently co-prescribed, and sleeping pills carry a risk of true physiological dependence, cognitive slowing, and extremely difficult withdrawal.
Now, Section 4. The stepped care model, a policy solution.
So, how do we fix this? While pills are absolutely essential for moderate to severe cases, the stepped care model offers a brilliant administrative framework, authored by experts like Dr. Jeel Vashah and Dr. Richa Sheth. This model dictates that for milder issues, psychosocial interventions, like basic counseling, must be the absolute first step before we even think about initiating pharmacotherapy. You manage the mild distress with therapy first and only step up to medication when it's truly necessary.
Section 5, community case studies. Evidence for GS1.
Listen up, because this is high-yield material for illustrating answers on social empowerment. We have two fantastic empirical examples of localized task sharing. First, Dr. Dixon Chibanda's Friendship Bench over in Zimbabwe. They trained elderly women to deliver structured therapy right on park benches, which led to a massive 43% reduction in depression. Now contrast and compare that with India's own Atmiyata program. This initiative uses community volunteers to provide basic emotional support, identifying local care needs and acting as a crucial link to formal services.
And building on that community aspect, we need a truly sociologically sensitive viewpoint here. Think back to that 85% treatment gap. Where are these people going? Well, many turn to faith-based healers and community elders first. So as future administrators, your policy shift shouldn't be to just blindly dismiss these traditional systems. Instead, you've got to build pathways to integrate them, train them to identify severe distress, and refer those patients to formal mental health services.
Finally, Section 6. Administrative synthesis, safeguards, and referrals.
Ma'am, this perfectly tees up our final administrative synthesis, which is exactly the kind of balanced, forward-looking view you need for the personality test. We absolutely must decentralize brief psychosocial interventions to train community members to bridge the gap, but we must also establish strict referral pathways. Community care complements, but it never ever replaces expert psychiatric help. Specialist care absolutely has to be reserved for severe conditions like schizophrenia and bipolar disorder.
And that brings us to the end of today's explainer. Aspirants, here is your direct UPSC mains question for practice. How can decentralized therapy and the stepped care model bridge India's 85% mental health treatment gap? We strongly challenge you to frame your own 250-word answer today.
Use the 85% data point, mention the Atmiyata program and the Friendship Bench case studies. Synthesize it well, stay focused, and keep studying hard.